So just a quick review of skin and skin cancer. Skin's basic makeup is the epidermis, dermis, and the hypodermis, and then the basement layer of connective tissue and fat. Um, Closer inspection of the epidermis, you have the from outside to in, the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basal. So the stratum corneum is anucleated barrier function. So basically, the keratocytes start in the basal layer, and then take about 2 weeks to work their way out all the way to the top layer, or the stratum corneum, where eventually they're shed. The stratum lucidum has different thickness depending on where it is in the human body. So the soles of the feet, it's a couple of millimeters thick, but in the eyelids, it might be absent or very, very thin. And then the stratum granulosum is where the keratinocytes lose their nucleus and become anucleated. And then in the stratum spinosum is when you have immune active cells are located there, and that's when a lot of the barrier function and host protection is there. And then the stratum basal, that's where the melanocytes are, which give color, make the pigmentation melanin to give the skin its color. And then you have Merkel cells, which if you are in the fingertips, you have lots of Merkel cells. They link to the nerves and give you sensation in the skin. So if you have them in your feet, you don't have as many, but in your fingertips, you have a very dense amount of Merkel cells. So skin cancer, most common type is the basal cell carcinoma, and that's the most common. UV damage is going to be a risk factor for all skin cancers, and this is mainly affecting the head and neck. It's most commonly seen on the nose, and that's where it's called the rodent ulcer. It doesn't have a tendency to metastasize, and it's described as having rolling edges with pearly papules, and then telangiectasia is formed on the top of it, and they can bleed. The reality of all of these basal cell and squamous cell carcinomas is very difficult to tell the difference clinically. You just know that they need to all be cut out and examined. So this is what a basal cell carcinoma or rodent ulcer looks like. You can see the pearly edge, and then you can see a bit of telangiectasia, so new blood cell recruitment on the top of it. This is hopefully someone's nostril. And then squamous cell carcinoma, hands and faces as well. They're unlikely to metastasize, but they can metastasize, and they often are fast growing. They're ulcerated red lesions, and they're associated with immunosuppression and UV exposure. And a pre-malignant condition would be actinic keratinosis, and that's in skin damage. When you see people that work as farmers or out in the sun all day, you'll see they have red skin with telangiectasia and lots of skin damage. And 20% of them will go on to get an SCC, or squamous cell carcinoma. And then the next one is a keratocanthoma, which is basically from a hair follicle, and you'll get a rapid growth over 4 or 5 weeks, and then it will bleed, and then as it grows so fast, it will outgrow its blood supply, become necrotic and die. But 5% of those can become squamous cell carcinomas. That's what a squamous cell carcinoma looks like on the nose. So it's red and ulcerated. And then finally you have melanoma, which is the most dangerous type. And you remember A, B, C, D, E. So A for asymmetry, B for the borders look irregular, C is the color, which is usually a change in color, and D is the diameter as it starts to grow and change in size, and E is evolving over time. So if you remember that when examining a lesion, then hopefully you'll know what you're looking at. The Breslow depth and the Clark level is a way of working out the treatment options and the prognosis, and it's done after you've done a wide local excision, so that you want an excision margin of 1 to 2 centimeters, and then you check the depth of it. So a Breslow depth of 4 millimeters, which is the deepest depth, has a 50% chance it's metastasized. And then the Clark level is another way of looking at it. Clark's level is not done on distance, it's done on which layer it is. So the worst layer it can be in is subcutaneous fat, which means it's gone all the way through epidermis, dermis, and all the way down through the connective tissue into the fat. It's least common melanomas, but it makes up 75% of the mortality, and it can metastasize to the brain, to the lungs, and to the liver, and to bone. And S100 protein, which is derived from neurocrest cells, can be taken on serum. So you treat with excision, a wide local excision, as you said, and then you stage it, and then depending on what you find, you might need neoadjuvant chemotherapy, and it's treated with a multidisciplinary team outlook. And that's what a malignant melanoma looks like. So it's a regular color, regular borders, and that needs excision as soon as possible and staging.